Seven County Services is your community mental health center with nationally recognized treatment for adults, children, and families in need of services that include mental health, substance use treatment, intellectual and developmental disabilities, crisis response, and more. Seven Counties meets the community where they are by providing a positive approach tailored to the individual needs of every person, regardless of a patient's background or financial status. Seven County Services, your journey, our passion.
Hello, my name is Lee Taylor, and on behalf of the co-conveners, the Department for Behavioral Health, Developmental and Intellectual Disabilities, and Mental Health America, Kentucky, I just want to welcome you to this year's System of Care Academy. It's our 10th anniversary, and we're super excited that you're here with us to celebrate. I'm going to go over just a couple of housekeeping slides before we introduce the presenters. Our session today is in Zoom webinar. That means that all attendees are muted and the videos are off. We are recording the session and we will have it available soon on the System of Care Academy website. Please use the Q&A feature at the bottom of your screen for presenter questions. We have a lot of material to cover today, so we're going to hold all the questions till the end, but if you put the questions there, the presenters will be able to see them and might be able to answer them along the way. We also have an American Sign Language interpreter with us today, and one of them should be on screen throughout the session. If at any point you can't see the interpreter, please put that into chat. We are also using auto captioning today. If you do not see the captions, click on the CC button at the bottom of your screen. And next, let's cover continuing education and certificates of attendance. You must be in the content portion of the webinar for at least 90% of the session to be eligible for a certificate. This is a mandate by the boards. You are not required to sign in by chat. Zoom captured your sign-in when you entered your email address to enter. And that email address is the unique identifier used to track attendance for certificates. So you must use the same email address when registering for and entering every single session. That's really important for your certificates. Within 2 weeks, if you are present for at least 90% of the session, you will receive an email from me with the session evaluation link. When you complete the session evaluation, you'll proceed to the certificate, and from that page, you can either print it or save it. We do not mail or email those. You guys can access that website at any time to get your certificates from 2019 through 2024. So now I get to introduce our presenters. Today's session is Selected Innovations in Response to the Crisis within Kentucky's System of Care. And it is an honor to have with us 7 Kentucky leaders. I'm going to introduce them by agency, and I'm going to start with the Kentucky Department for Behavioral Health, Developmental, and Intellectual Disabilities. Beth Jordan has served as the program manager for the Children's Mental Health and Recovery Services branch within the department since 2014. And prior to that, she served as program administrator in the branch for 17 years. Prior to her state government career, Beth worked as a child, youth, and family outpatient therapist in Texas and for Bluegrass Impact. Beth holds a bachelor's degree in sociology and psychology, a master's degree in clinical psychology, and a graduate certificate in children's mental health. Beth has served as the project director and/or principal investigator on all 6 of Kentucky's System of Care grants, and she's worked on numerous other federal grants. Beth is a content expert on children's behavioral health, the System of Care framework, cross-agency collaboration, family and youth engagement, early childhood mental health, behavioral health needs of children involved with child welfare, and implementation science. Dr. Tina Robbins is the Senior Executive Advisor for Innovation and Implementation Support within the department. In this role, Tina serves as the lead staff for behavioral health innovation, implementation, and system transformation efforts. She has over 30 years experience in the behavioral health services field as a behavioral health services researcher, program evaluator, and program administrator, and has direct care experience in early care and education as an elementary school counselor. Tina received a bachelor's degree in psychology from Berea College, a master's degree in community and school counseling from the University of South Florida, and a doctorate in child and family research and policy from the University of South Florida. And our next agency is Department for Community-Based Services, which you'll probably hear referred to as DCBS during the presentation today. Mary Carpenter is an executive advisor with the department. She started her career as a frontline social worker in 2004 and has held various positions since then. In Mary's current role, one of her focuses is expansion of primary and secondary prevention efforts to promote well-being in families and communities, which includes an emphasis on engagement and lifting the voice of parents, youth, and other partners who have been or are involved with the child welfare system. Mary earned her bachelor's degree in social work from the University of Kentucky and her master's degree in social work in 2007. Dr. Lohr is a professor in the Division of Child and Adolescent Psychiatry and Pediatric Psychology, Department of Pediatrics at the University of Louisville School of Medicine. Since January 2018, he has served as the Chief Medical Officer, Medical Director of DCBS. Dr. Lohr has published and presented on trends and quality concerns concerning the use of psychotropic medications in children and the importance of trauma-informed care of children in the child welfare systems. Next, we have Department for Medicaid Services. Leslie Hoffman is a Deputy Commissioner for the department with oversight to the Division of Long-Term Services and Supports, the Division of Quality and Population Health, and the Behavioral Health Innovation Branch. She was formerly the Chief Behavioral Health Officer at Department for Medicaid Services. And Leslie acted as the Commissioner's lead for the Kentucky 1115 waiver evaluation, the SUD, substance use disorder 1115 waiver, incarceration waiver amendment, mobile crisis planning grant, multi-systemic therapy pilot, and certified community behavioral health clinic initiatives. Leslie continues to serve as Medicaid's champion for racial and health disparities. Previous jobs include Behavioral Health Director and Director of Community Alternatives at the department. Leslie has a bachelor's degree in psychology from Campbellsville University, a master's in education from Western Kentucky University, and is completing a doctorate in business with a specialization in leadership management from Campbellsville University. Sherry Staley is a behavioral health supervisor with the Department for Medicaid Services. She's been with the department since 2017 and previously worked as a clinician for children and families. Sherry's primary focus is on Medicaid children's behavioral health projects and initiatives. And last, we have Kentucky Partnership for Families and Children. Tammy Blevins is the Executive Director of Kentucky Partnerships for Family and Children. We'll refer to it as KPFC. Tammy is a management and operations professional dedicated to elevating human capital through relationships and process improvements to systems, institutions, policy, and practice. She values compliance and continuous quality improvement via cross-functional team and community collaborations. A respected advocate on the volunteer and civic engagement fronts, Tammy is fueled by belief in helping individuals recognize their full potential and creating opportunities for others to experience success. She appreciates the role of diverse perspectives, along with the value of lived experience in facilitating improved outcomes and well-being. Tammy has a master's in management science from Indiana Wesleyan University, graduate coursework in industrial organizational psychology from Northern Kentucky University, and a bachelor's in sociology criminology from Ohio University. And I'm going to stop sharing for 1 second to switch to the presentation.
While you're doing that, Lee, thank you for that extensive introduction. As you can tell, we have people with lots and lots of experience on our panel. So welcome to our collaborative session, and thank you so much for joining us as we celebrate Kentucky's 10th System of Care Academy. While many professional development opportunities paused and regrouped during the early years of the pandemic, I'm proud to say that our academy has operated without stopping. We appreciate the opportunity to share with you some of the creative ways that our system of care partners responded to the crisis in children's behavioral health that was present prior to 2020 and brought to the forefront both nationally and in Kentucky before and after the pandemic. Go to the next slide, Lee. The learning objectives for this, by the end of the workshop, you should be able to describe the nature of the behavioral health crisis in Kentucky for children, youth, and families, discuss Kentucky's collaborative response to the behavioral health crisis, including infrastructure and cross-agency service responses, and share reflections on how to leverage system crises into system opportunities. So our panel talked about removing this slide. A lot of this comes from a previous presentation, but we realized that we may have some folks on this webinar that are not from Kentucky. So we want to make sure that we paint a little bit of a picture of the Commonwealth for everyone who's participating. Kentucky is probably best known for horse racing, bourbon, tobacco production, and coal. And while these stereotypes are accurate, the rural nature of the state often contributes to isolation, limited access to resources, and a reliance on family and community rather than institutions such as government. Kentucky is unique in that we border 7 contiguous states and has the 4th greatest number of counties in the nation, despite its relatively small size. Citizens from many rural border counties can more readily access large urban areas in the contiguous states, thus impacting both workers and service recipients. These factors, we believe, impact the behavioral health workforce shortages we've experienced for years and complicate coordination of behavioral health services across county and state lines. And you can see just a few little demographic bullets there on the slide. All right, thanks, Lee. As we mentioned previously, there are both environmental and system factors that have contributed to the ongoing crisis in children's behavioral health. Many of these factors are common across states, while some are unique to Kentucky. Next slide. Like the rest of the nation, Kentucky is experiencing a child and youth behavioral health crisis. In addition to COVID-19, heightened political discord, behavioral health workforce shortages, and racial injustices, which were experienced by many states, Kentucky families have experienced state-specific stressors, such as multiple natural disasters, including one just this past weekend, a school shooting, escalating community and school violence, high rates of parental incarceration that result in separation of children from their primary caregivers, and high rates of youth living in kinship placements, as well as the continuing impact of the opioid and other substance use crisis, many of these preceding the pandemic and national acknowledgement of this crisis. So those were some of the environmental contributors. We also have multiple system level contributors. Historically, Kentucky has had a limited focus on workforce pathways. Until very recently, there was not a dedicated focus to behavioral health workforce development in the state. The limited attention that was given focused primarily upon the provision of professional development opportunities for the current workforce. Another system barrier is the inconsistent adoption of the system of care approach across child-serving agencies. This is especially evident in the continued presence of parallel mental health service systems for youth entering either through juvenile justice, child welfare, behavioral health, or education. The way in which a child makes first contact with the system heavily influences their care pathway. Kentucky also has extremely limited integrated treatment options for youth who have co-occurring mental health, substance use, physical health, and/or intellectual and developmental disabilities. As a result, families and youth are left to navigate across systems and providers, which opens them up to potential conflicting treatment goals and service goals, as well as potential duplication and fragmentation of services. Another system level factor is an inconsistent political and policy landscape that prioritizes mental health and well-being, particularly for children and youth. Kentucky ranks 45th in per capita spending on mental health. Significant state funds have not been allocated to the State Mental Health Authority for children's behavioral health in many years. The 2023 State of Mental Health in America report from Mental Health America ranked Kentucky #1 for adult mental health and number 31 for children's mental health. Thus, the state has been forced to rely heavily upon discretionary, time and geographically limited grant funds to fund innovations in addressing the children's mental health and substance use crisis. While these funding opportunities have supported the adoption of many innovative programs and practices, others were not sustainable without additional funds. Lastly, Kentucky has never had a comprehensive plan for children's behavioral health. There have been myriad plans, either specific to a project or a grant or adopted by an individual agency, but never a plan that's been comprehensively adopted by all major child-serving systems. I'll turn it over to Tina to talk about some of the other impacts as a result of these contributors.
Thank you, Beth. So now that we've discussed some of the environmental and system level contributors to the crisis, let's shift to a discussion of some of the impacts of this crisis on both individuals and on the system. So this slide here reflects trend data from the Kentucky Incentives for Prevention, or KIP survey, as we call it, which is administered biennially in Kentucky school districts that volunteer to participate. This is our largest source of behavioral health surveillance data for youth in Kentucky. It's important to note that the KIP survey was not administered in 2020 due to COVID, so we don't have data for that particular year. As you can see, all student participants experienced increases on several mental health indicators, with self-reports of serious psychological distress showing the most significant increase over time at 57% between 2014 and 2021. We've seen increases in suicidal ideation, suicide planning, and suicide attempts, all of those hovering around a 20% increase over that time period. Notably, sixth graders experienced the largest increases on these indicators, with rates of suicidal ideation and planning more than doubling during this time period, again, between 2014 and 2021. It's important to note that survey data are not collected with those younger than sixth grade, so we're really not fully aware at all of the impact on elementary age children. However, we do have anecdotal data that suggests that reported rates are increasing among those younger than 11. So there has been a tremendous impact on mental health well-being among our children and youth. Next slide. So let's take a look at substance use. This slide, also from the KIP survey, illustrates trends in substance use among participating youth. And the top figure shows a decline in past 30-day use of illegal substances, alcohol, cannabis, non-medical prescription drugs. Kentucky's self-reported use remains below the national average for 10th and 12th graders. Self-reported use of vapes, smokeless tobacco, and cigarettes also declined among youth in 2021. However, those rates remain higher than the national average, and this probably doesn't come as a surprise to any of you, but vaping continues to be the leading form of nicotine use among our youth. The illustration on the right shows the relationship between substance use and mental health. Those who misuse substances have a higher likelihood of experiencing psychological distress. For example, those who smoke cigarettes are 3 times more likely to report serious psychological distress. And so there is clearly a strong relationship between the two. Next slide. As this slide indicates, rates of suicidal ideation and attempts, as well as substance use, are substantially higher for Kentucky's students that identify as LGBTQ+, and most significantly, those who identify outside the gender binary. Non-Hispanic, multiracial youth in Kentucky were most likely to report serious psychological distress and suicidal ideation. And it's important to note that these significant nuances, these significant differences could have been overlooked if data had not been disaggregated by sexual orientation, gender identity, and race and ethnicity. So it's important to do that disaggregation of the data. Next slide. As Beth mentioned, racial tensions have served as an environmental contributor to the children's behavioral health crisis. The KIP survey recently added questions to evaluate the impact of racism on youth reports of mental health well-being and substance use. The bar graph on the left shows the percentage of students in all grades participating in the survey reporting that they personally experienced racism. Among those youth, those identifying as non-Hispanic Asian and non-Hispanic Black had the highest reported rates of being a target of racism. Reported rates on mental health and substance use indicators are all 2 to 3 times higher for those who have personally experienced racism. For example, those experiencing racism are more than 3 times as likely to report a suicide attempt and at least twice as likely to report using substances. So again, a strong relationship exists between the experience of racism and mental health well-being and substance use. I'll now turn it over to Dr. Lohr to discuss system-level impacts.
Thank you. Yeah, so in addition to the individual level demographics and changes that we were talking about, the crisis affects the system as a whole in a lot of different ways. If you think about the system of care as a spoke and hub where all the different spokes from the individual, each of these systems are impacted. So in school, you see a lot more missed days, absenteeism or truancy since return to in-person instruction. You have some children that really struggle with the return to in-person schooling and they have missed days. And so we're seeing more referrals for truancy and complaints from the judicial system. The crisis has taken a toll, and I really think of this as happening since the COVID pandemic. The workforce is changed in the state, and it's much harder to have facilities, hospitals, homes, foster homes staffed appropriately. So there's a big gap in access to care because of we don't have enough workers. There's a tremendous workforce shortage, and it's hard work, and it's a matter of all hands on deck. So it's really, you have situations where facilities are stretched to their breaking point across the system of care. And, you know, when you have a system that's stressed with workforce issues and acuity is increasing, you start to run into safety concerns, either in facilities or in the community. And so you have that happening as well. Childcare can be an issue. I'm sorry, previous slide, please. Thank you. Childcare still is an issue that you have trouble with access to childcare. That's workforce and acuity as well. So across the board, we're seeing an increase in acuity of behavioral health needs, not only in juvenile justice placements, but in placements through Department of Behavioral Health. That includes foster homes, residential facilities, inpatient hospitalizations. And so as a result, you're seeing that we are struggling to really serve the needs of these youth. And we've developed a term called high acuity, which for us means a youth with intense behavioral or emotional needs that puts them at risk for losing their placements. And when a child loses a placement, they can become part of what we call a non-traditional placement. This is any child that's in a facility or a place that really they shouldn't be in. So it can be an emergency room for a child that's been considered psychiatrically ready for acute hospitalization, but there are no beds. So they may be, quote, boarding in a non-traditional placement in an emergency room, but it can also mean DCBS offices or hotels and even emergency shelters. So we're seeing a lot of different places where youth may be having to stay, and it affects our world of DCBS a lot, mainly because we serve the most vulnerable youth and families. Next slide, please. So we do track this, and this is a trend line of non-traditional placements. Starting in July 2022, when we first started really noticing this developing, we track each month the number of unique episodes and the number of youth involved. And you can see that each month there is some waxing and waning, there's some give and take, but certain months are really crises. And any of us who have worked in child psychiatry, child mental health understands that the spring of the year as school ends is often a crisis. And so you see this really spike in May and June of many years across the system. So in our case, we saw a spike last year in non-traditional placements. Next slide, please. And I will turn it over to Beth Jordan, please.
Thanks for that prompt, Dr. Lohr. Now that you've heard a little bit about the nature of the crisis and its impact on both individuals and the system, we're going to shift to a discussion of some selected innovations undertaken in response to the crisis.
Beth, you're muted.
Thank you. Kentucky's collaborative response builds on its 35-year history of implementation of the system of care approach. Our system of care in Kentucky provides a strong mechanism through which there is shared accountability and responsibility for system reforms, improvements, and responses, including those that emerge during crises. As a reminder, or maybe a first-time lesson for some folks that haven't had the opportunity to learn about the system of care yet, but the approach consists of 3 necessary elements. It requires a philosophical framework to drive necessary infrastructure changes that support and sustain the implementation of effective services and supports. So a framework, infrastructure, and services and supports are the 3 necessary elements. Today, you'll hear about numerous cross-agency innovations in both the infrastructure and service delivery system that align with the system of care philosophical framework. All of these innovations in response to the crisis were possible because of the collaborative nature of Kentucky's system of care. So the first required element of the system of care is the philosophy, and that consists of a definition, core values, and guiding principles. Here you can see the definition of a system of care, and I won't read it to you, but you'll notice that there are some key words that are bolded, and I think those are things that we all value and hold important as we work with families and children. While the definition has been updated periodically since its original inception in 1986, it has retained the original intent while incorporating emerging trends in the field of behavioral health. So some of the wording has been changed to bring it more current and expansive. However, the intent is the same. These are the 3 core values of a system of care: that it is family and youth driven, that it is community based, and it's culturally and linguistically responsive. These core values have remained intact since the original conceptualization, in that the 3 values have always centered on youth and families, communities, and culture and language. This is a list of the system of care guiding principles. And these principles are how the core values are operationalized in practice. These have been revised extensively over the years to become more expansive. For example, you can see the addition of mental health equity, the incorporation of the public health approach, and trauma-informed care. These are principles that have been added as research demonstrates what is most effective when serving families and youth. So Tina's going to talk a little bit about the collaborative response at the infrastructure level.
So Beth just shared the philosophical framework guiding Kentucky's response to the crisis, and now we'll describe selected system of care infrastructure strategies that have been undertaken. Next slide, thank you. So let's start with how we leveraged our existing governance structure. Kentucky is very fortunate to have a statutorily established governing body for its system of care that has been in existence since 1990. And this governance structure consists of the State Interagency Council for Services and Supports to Children and Transition Age Youth, or SEAC, as well as regional interagency councils, which we refer to as REACs. These governing bodies are responsible for expanding, improving, and sustaining the system of care. Next slide. So this already existing governance structure afforded Kentucky the opportunity to respond quickly in a collaborative manner across member agencies, which you can see here on the slide, as well as with families and youth with lived experience who serve on the council, as well as lots and lots of stakeholders who serve on some of the standing committees that the State Interagency Council has in place. Next slide. This is an illustration here of the regional interagency councils, or REACs. So similar to its state counterpart, the regional interagency council structure mirrors state required membership, but also allows for localization of membership based on needs and assets. So again, Kentucky was able to quickly leverage these existing local governance structures to respond in a collaborative manner. I'll now turn it over to Dr. Lauren Mary to discuss planning and development innovations.
Okay, I'll take the first 2 items here. So at the cabinet level, you have a number of workshops and committees that are involved in trying to understand and address the needs of the crisis in a system of care manner. And The first is the Standing Committee of the SEAC, includes the Service Array Standing Committee that works to understand the needs. And these committees include members from family-run organizations, juvenile justice, administrative office of the courts, child welfare. And so it offers a forum for communication and coordination for these activities. And so we're meeting regularly. And in a group that I'm involved in, youth with high acuity behavioral health needs, which we call Transformations for Learning and Care, TLC, that really focuses on the non-traditional placement, the high acuity youth for DCBS. And so we have a cabinet level agency meeting of leaders that looks to understand the problems and come up with needs. And it allows us to keep the needs in front of the leaders and fosters effective cross-agency work. Mary?
Thanks, Dr. Orr.
Yeah.
So the SEAC is also working with the Innovations Institute at UConn to conduct a care pathways analysis, which is mentioned here. And during a care pathways analysis, a family's experience through the system of care is mapped visually based on data. And this map allows for the identification of points along that pathway for system leaders to really intervene and change the experience of families and address those identified problems. So interruption points are opportunities for system leaders to change care pathways and or create new pathways. So Kentucky's working with UConn to engage with partners from across the state to develop its first ever comprehensive children's behavioral health plan. This plan is going to reflect common sets of priorities, goals, objectives to really guide all major child-serving agencies, funding sources, and other partners in how we serve families across the state. And then Thriving Families, Safer Children is a first ever really movement in how we envision child welfare. So it's a partnership with the Children's Bureau, Annie E. Casey, Prevent Child Abuse America, and the CDC, the Center for Disease Control. Really, it's in 22 sites, but Kentucky is also a site, and it's really thinking about building community well-being and promoting outcomes for children and families. So in Kentucky, it's a collaborative movement and partners, all the partners that you see here, as well as the Administrative Office of the Court, individuals with lived experience, to really think about child welfare and a new way of promoting primary and secondary prevention to prevent families from ever coming to the attention of DCBS. So we're in our third year, and the goals are to develop a robust network of community-based prevention supports, creation of formalized structures to serve families screened out by DCBS. So those reports that come in that do not rise to the level of abuse or neglect, clearly differentiating between poverty versus neglect, and creation of a parent advisory council, which we call Kentucky Seat. And next slide. And this is Tammy.
Yes, thank you, Mary. So we've talked about lots of acronyms, lots of contributing variables or factors. And in the conversation around a collaborative response, this would be the third bullet under the infrastructure piece. So we have the people, we've got the ideas, we've got the innovation and development, but we need permissions, we need access, we need funding. So that is where policy comes in. And you can see several of the different headings here. I know we've already talked about so many acronyms, But there are some just specific pieces of legislation that I'd like to highlight just to mention, and then I would direct folks to Kentucky Youth Advocates has some wonderful information if you'd like to learn more in depth. But basically, we had some significant efforts and decisions undertaken by our General Assembly this most recent session around policies that really serve to support children, families, and those who serve them. So in the area of education, we had Senate Bill 2. I'm not going to read every bullet point here, but it kind of really is a domino effect when you think of all the domains and just one piece after another, how they build upon each other. So in child welfare, we had Senate Bill 151. We also had the House Joint Resolution 116. These are just some things that over time, right, we've all been around a while, and we've recognized that we don't have enough beds available or placements or homes. So really thinking outside the box and leveraging those pieces of families and other fictive kin who are willing to help children in need in out-of-home placements. Also, you see that third bullet point under child welfare, just kind of helping set the rules, so to speak. So, you know, there are opportunities available that if folks don't necessarily meet a certain threshold, good or bad, they can still receive the services, excuse me, that they need. Moving on to health, we talked earlier about vaping and the dangers that those pose to youth. So a few things, I think some folks wanted some stronger language, some stronger parameters, but we got a little bit there. So we do have restrictions for those. There are very important resources now made available through the review of unfortunate information to help improve maternal health outcomes moving forward. Moving on to economic security, housing is obviously a huge issue, something that all of us probably encounter in our respective services. So I believe that was, I forget the specific number for that one, please excuse me. But I've got 68 written down here in my notes here from the House. And again, looking at contributors, looking at resources, looking at services. Early childhood, this was a huge winner, so to speak, if this is the realm that you work in or you somehow touch in your world. So lots of conversations around expanding childcare access. We had House Bill 561. We had record investments contributed to this area. And they all come together for that final list there of the budget bills. These are just some of the more, again, in our world, some of the more significant measures and decisions that have been put into place. And what I like to say is in the old world, we always talked about unfunded mandates. Well, now there is actually money behind a lot of these things. So $20 million when it comes to establishing a medical fund for youth in care of juvenile justice. And I'd like to point out that that is both physical and mental health. You heard Dr. Laura mention previously high acuity juveniles mental health treatment. So the reason this is so important is, again, in the world of out-of-home placement, you know, what it used to look like when you couldn't necessarily meet the specific treatment needs of a youth. So there are some behaviors that are especially concerning, and you know they pose a risk for everyone involved. Some of those are in the high acuity definition. It's manifest aggression, violence toward persons, or property destruction. Again, these youth still have needs. So there's some exciting work going on in that area. And last but not least, allocations for early childhood programming, excuse me, and school-based mental health providers. So there was a commitment to $70 million annually around that early childhood programming, and then an increase in SEEK funding, another acronym there, but basically providing options once again for school districts to use their money in ways that can benefit, both the districts, the staff, and the students. So that was a mouthful. Thank you. Now I'm going to pass it on to, I believe, Beth, you're next.
I think it's actually me.
I hope it's Tina.
It's Tina. It's Tina.
Thanks, Tammy. So that was a wonderful overview of, all the policy pieces. You've heard about governance, you've heard about planning. Another big area, infrastructure area, is workforce development. In the human services field, humans are the intervention, right? And so we're only as good as our workforce. And so our department, the Department for Behavioral Health, Developmental, and Intellectual Disabilities, has prioritized behavioral health workforce innovation and development in response to the workforce crisis and the children's behavioral health crisis in turn. A number of strategies and initiatives are being undertaken as part of our, what we call 25 by 25 workforce innovation and development plan. So in this plan that we're going to be releasing in the next few weeks, there are 25 workforce initiatives with benchmarks that we plan to achieve by the end of 2025. So that's where the 25 by 25 comes in. And these various workforce initiatives fall into the domains you see listed on the slide. So you see 5 areas there. This is our strategic framework we've adopted for workforce. For example, we have strategies that focus on the collection and analysis of workforce data. So that's understanding workforce needs. We have strategies that are focused on recruitment, and that's increasing the supply of the professionals. And that's apprenticeships and training scholarships and things of that nature. We have strategies that are focused on expanding the reach of existing professionals to meet increased demand for behavioral health and intellectual and developmental disability services. So we're working very closely to increase the behavioral health competencies of workers like community health workers and peer supports and primary care physicians, to name a few. We also have strategies, workforce development strategies, that promote the equitable distribution of professionals in underserved areas. We do this through strategies such as increasing access to telehealth and creating training scholarships for students to work in rural areas and marginalized and minoritized communities. And then we also have strategies that focus on retention of high quality professionals. It's one thing to recruit these folks, it's quite another to retain them. And so we focus on things such as increased professional development opportunities, which promotes retention, workforce resilience initiatives, and so forth. And so all of these strategies in combination are leading to a redesigned workforce for a redesigned system of care. And so next, we're going to hear a little bit about some of the DCBS, or Department for Community-Based Services, workforce initiatives.
Thanks, Tina. So similar to we did, we began focusing on workforce recruitment and retention strategies in our department about 2 years ago. We were seeing significant turnover in DCBS. So in 2022, we partnered with Eastern Kentucky University, who provides our training for our newly hired protection and permanency staff. And we also looked at our training. We really worked with them to redesign our training that we were providing, and reformatted that. It's now the Foundations in Child, Family, and Adult Services training. So really looked at more competency-based, skill-focused learning training for our staff, and providing them with more support on the front end. And in addition to that, we updated our training curriculum related to our public child welfare certification. So that's our partnership with our universities for incoming students. And then, we have a program where they have an agreement with us to remain with us for 2 years. So we actually moved that to University of Kentucky. So it's now known as CW Prep. So it's prepare, retain, engage, and partner. And so we've done a lot of different supports for those other partner universities with that program now, a lot of changes around how that's operating, and that's still ongoing work. We've made a lot of pay grade adjustments, a lot of additional raises in partnership with the legislature, and work to reclassify employees, doing pay grades, shift premiums were implemented for after hours and emergency situations, offering locality premiums for certain areas of the state. We also began using certain media campaigns for recruitment of employees, really advertising that we were shifting the way that we were doing business at DCBS. We implemented a trauma and resilience community of practice, so working to implement self-care strategies and professional development around how we support our staff. We did some different other recruitment platforms as well, and then implemented an interim hiring process so that we could actually onboard staff quicker. And we have seen some improvement around our turnover back in over the last couple of years. I guess from starting in 2021 through 2022, we were seeing around 12 to 20% in turnover for all of DCBS, and we're around like 3%. So we've seen a pretty significant improvement in our turnover. And then one last thing that I'll mention is just our partnership with behavioral health, and we have through the System of Care grant been part of at DCBS, and then they've also included other partners in their interview panel, which I think is just really shows our partnership, and thinking about that cross system collaboration, and thinking about how we're interacting, and just that shared strategy and partnerships in those workforce supports.
I think Leslie's going to kick us off on some equity discussion.
Yes, my turn. So I just wanted to go over a little bit before we kick off on the bullets that what a vested interest and what a wonderful opportunity that the cabinet has really been working on related to racial and health equity. The vision of the cabinet, our Cabinet for Health and Family Services, is for a commonwealth where all Kentuckians can reach their maximum goal, and that all communities can thrive. And we believe that we accomplish this through our continued work to operationalize equity pillars through all our programs, our divisions, our departments, and we all work collaboratively together, which is another awesome initiative that we've all been working on. Our cabinet's an organization embedded in learning culture of humility, and encourages self-awareness and participation in the enhancement of racial and health equity. We utilize a lot of things like data and to inform policies and procedures. We utilize it to help with programs and contractual agreements, and to advance health equity for all Kentuckians here. The equity vision is strategically shared across the cabinet, as I said before, through all of our divisions and departments. And we also utilize our stakeholders through effective collaboration to share those best practices and streamline the efforts. Health equity is absolutely one of the System of Care guiding principles, as well as one of the pillars for the cabinet's efforts. We have many, I could go on for quite some time about our equity efforts going forward, but we wanted to highlight just a few here that we feel that are most significant to addressing or responding to crisis. So Beth, I'll turn it back over to you.
Thanks, Leslie. We tried to narrow this down, but we were really excited about all the things we have going on around health equity and equity in general. But just to go through the bullets that are listed on your slide, as a result of the pandemic, we've been able to increase virtual services and support options by adding the ability to utilize telehealth during the pandemic, and maintaining this as a delivery option post-pandemic, which is fortunate. Many states reverted after the pandemic was declared over and we're not able to provide those services via telehealth. I want to acknowledge Michelle Sames's comment in the chat right now, though, that we need to have availability for in-person, in-school, and home and community, face-to-face services as well. We support that. We think there are many pathways to receive services, and supports telehealth is one that's effective for some people, but not everyone. We've also focused on improving language access. So leading up to, during, and since the pandemic, system of care partners saw an increase in requests for translation services for those who speak languages other than English, including those who are deaf and hard of hearing. And that's my note to myself to slow down for the interpreters. Through partnering with the Department for Behavioral Health, Developmental, and Intellectual Disabilities, Deaf and Hard of Hearing, and Equity Program Administrator, we focused on building budgets for written and oral translation services into new programs and budgets, simplifying pathways to access these services, and supporting existing and new partners and agencies to provide these services. Several initiatives we've had that focus on marginalized or minoritized populations. Specifically today, I'm going to talk about some for the Black, Indigenous, and people of color, or BIPOC, and LGBTQ plus, or lesbian, gay, bisexual, transgender, queer, or questioning populations. Among those are building competencies to address racial trauma within the system of care. Because training, coaching, and technical assistance are critical infrastructure strategies to ensuring a competent workforce, Kentucky offered and is offering again in the coming year professional development opportunities to build competency among system of care partners and practitioners to recognize and respond to youth racial trauma using a three-prong approach. So as you heard Tina mention earlier with the data, we do have a number of youth that are experiencing racial trauma, and those individuals are seeing more severe mental health concerns. So at the first level, we have partnered with Dr. Stephen Nifley to conduct racial trauma awareness sessions. This is to any system of care partner, anyone who interacts with youth, community partners, families, everyone. At the second tier, we had him deliver training and technical assistance on screening tools and referral processes for racial trauma treatment. And lastly, we supported Dr. Nifley in developing, evaluating, and implementing a developmentally appropriate racial trauma therapy protocol for children aged 6 to 12. He had already developed a protocol for age 13 and up, but we felt it was important to expand that work to a younger population as well. Our department also applied for and was awarded funding for Black youth suicide prevention. These short-term funds are being used to develop and empower a multi-perspective task force that will enhance strategic engagement and collaboration with organizations that support Black youth between the ages of 5 and 24, with an emphasis on agencies who focus on the mental health needs of the population in order to support them in serving Black youth most at risk for suicide. Finally, and this bullet's a little out of order, but related, the System of Care 5 grant was able to support the provision of a study and discussion groups of the Black Foster Youth Handbook. The full title is the Black Foster Youth Handbook, 50 plus lessons I learned to successfully age out of foster care and holistically heal. That is a mouthful. This was offered to youth in DCBS custody and residential care by our youth leadership coordinator that was hired through the System of Care 5 grant. All of these initiatives, let me jump down, for youth in the LGBTQ community, our department supported the 2023 launch of an ongoing provision of Camp Beacon, which is really an exciting opportunity. It's Kentucky's first summer camp for LGBTQ youth. This availability empowers and allows them to have a traditional summer camp experience in a welcoming, inclusive, and safe environment with their peers. And then one more equity initiative that I want to address, and we partnered closely with DCBS on this, was supporting conducting a Family First Prevention Services Equity Impact Assessment. I was trying to figure out how to say that more quickly there, and it just didn't work out. But DCBS worked with a consultant that we supported with System of Care 5 funding to analyze data and interview staff in an effort to better understand the use of data within the child welfare system and identify gaps and trends in this area in order to better serve children and families. So looking a lot of race data, gender, a lot of various demographic points throughout their services as well to improve services and supports. And all of these initiatives that I've mentioned utilize a trauma and grief informed approach. Tina is now going to talk about some activities specific to grief, trauma, and resilience.
Thanks, Beth. So like racial equity, trauma mitigation and resilience building is a system of care guiding principle and also a pillar of the Cabinet for Health and Family Services. And we have initiated several trauma, grief, and resilience-oriented initiatives in response to the crisis. And so you'll see many of these listed here. This is not an exhaustive list by any means, but these are just a few initiatives we want to talk about today briefly. Immediately prior to the onset of the pandemic, Cabinet leadership was becoming increasingly aware of the secondary traumatic stress experienced by lots of staff, but primarily frontline staff, particularly those working in child welfare and behavioral health. And this was obviously further compounded during the COVID pandemic. And so to address this concern, the Department for Behavioral Health, Developmental, and Intellectual Disabilities contracted with the Center for Trauma in Children at the University of Kentucky. And this is a national center. We contracted with them to facilitate, and this is a mouthful, secondary traumatic stress breakthrough series collaboratives. And we use an acronym for that, STSBSC. But they conducted those collaboratives for both regional child welfare and regional community mental health center teams. And this is really a process for organizations, systems of care, and departments who want to become more secondary traumatic stress informed. And it does this in a few ways, increasing the competency of staff to respond to secondary traumatic stress and trauma. It increases the capacity of the agency to plan and implement improvements that promote staff wellness and increase resilience. And then it also works to reduce the risk of exposure to situations and events that result in secondary traumatic stress and vicarious trauma. And so these collaboratives promote change through collaborative teams that include staff at all levels and engages the team in problem solving that recognizes the unique strengths and needs of each locality. And we're very fortunate to be able to continue to fund for, current and future cohorts designed for staff who work in juvenile justice and in the court system. And so a really large scale initiative there to focus on organizational change. I also want to point out an incredible resource that I hope all of you will take advantage of. It's the Well at Work website, again, created through a partnership with the Center on Trauma in Children at UK, and we'll make sure that you have a link to this website. But this particular effort was funded through some emergency COVID dollars that we got. And it really is meant to promote workforce resilience by, and we view workforce resilience as a retention strategy. So this is really a workforce retention effort here as well. We've done a great deal of work around workforce resilience in Kentucky, due in large part to having dedicated staff to this effort. And one of the initiatives, again, that I'm most proud of and that I believe has had a widespread impact and reach is the development of this Well at Work website. And we conceptualized the resources on this website in a multi-tiered fashion. At tier 1, there are universal resources for health and behavioral health providers. And I would say really that these universal resources extend beyond health and behavioral health providers and can be used by any number of professionals and should be accessible to all of them. One of the big features at the tier 1 level, in addition to resources are podcasts, and these podcasts can be accessed at any time. And they're short, easy to understand podcasts, and they focus on topics such as working in the midst of workforce shortages, promoting safety in the workplace, increasing psychological safety in the workplace, leadership practices to boost employee retention, and so forth. So please check these resources, these podcasts out. They're incredible. Tier 2 is more targeted resources. We use what's called a Project Echo framework to provide telementoring to organizations around different difficult and complex workforce types of conditions. And then at the third tier, these are more individual level resources. So there are screening and resource linkages for individuals to assess their own personal levels of stress and secondary traumatic stress and burnout and other types of conditions that can affect their workforce well-being. I also want to mention that the UK Center on Trauma in Children, again, will offer a learning collaborative on trauma and grief as part of the Kentucky 6 grant, and we'll probably have multiple opportunities for those learning collaboratives. And then, lots of agencies within the cabinet and outside of the cabinet for Health and Family Services are making great strides in training their workforce in trauma-informed care practices. I also want to put a plug in here for an initiative called PARC. This is a partnership for a resilient Kentucky, and PARC is a network of organizations and individuals that promote positive childhood experiences and resilience across the lifespan. And they're also addressing the impact of adversity and trauma on individuals, families, and communities. And they have created a sustainable sort of mechanism for the dissemination and support of integrating science and best practices around resilience across the state. They gather, multiple times a year to highlight best practices and research promoting resilience. And so if you're not familiar with PARC, definitely check out the website. And again, we'll make sure that you get that. This group is open to anybody who's interested. And then lastly, there's a newer resource in the state called the Center for Grieving Children and Families. You can find them online as well. And they offer grief support services, both virtually and in person across the state. And so just lots and lots of tremendous work going on in the area of trauma, grief, and resilience. So on the next slide, you'll see that, we've talked about our collaborative responses at the infrastructure level, and we had quite a few of those. We also have several service system initiatives in response to the crisis. And so I'm going to turn it over to my colleagues in Medicaid now to share a few of the crisis system expansion efforts. And I do want to do a time check. We are about 30 minutes from our end time. And so I just wanted to give folks a time check.
So I'm going to start with the crisis system expansion, which we have lots of things going on in the cabinet. We partner together, all of our different divisions and departments on a lot of things, which is always exciting. Some of our other services, as you can see here listed, innovations in response to crisis have been centered on just trying to expand Kentucky's crisis system. Like many other states, we have been very immersed in the 988 implementation. 988 crisis hotline calls that now are fully covered by the 14 community mental health centers, who are also now national suicide prevention lifelines, and they're covering all 120 counties. And that's a huge effort and a completion to get that done. DBH also has a pilot of a paramedicine or paramedical and emergency medical technician, which is the acronym is EMT, crisis response effort. and that's in a rural community. It was designed to and developed to expand the role of paramedicine as behavioral health mobile crisis response providers. Also to partner peer support specialists with a paramedical team to support peer support specialists in becoming EMTs, to increase local as well as individual capacity. It is also to be able to support and develop the development of the toolkit replica of best practices that we have been provided with. DBH also has a lot of disaster response efforts. So in addition to the 988 enhancements, we also have mobile crisis spa definition to Fidelity recently in Medicaid. And then we also have co-response models, and we have been building capacity around disaster response. As we mentioned earlier, Kentucky families across the state have experienced a multitude of crises over the last couple of years. We've got in Western Kentucky the tornadoes, and in Eastern Kentucky the flooding. I think most areas have also been compromised by the high winds and most recent rainfall. In response, DBHDID has secured disaster behavioral health grants from both SAMHSA and FEMA to provide counseling and disaster case management to individuals impacted in those areas. And we are very lucky that they took on that initiative quickly to get help out as quickly as possible. We also have school crisis response teams. These school crisis response teams in partnership with Kentucky Department for Public Health. DBH is also working with educational cooperatives, the Kentucky Association for Psychologists in Schools, the Department for Education, and other subject matter experts to coordinate this crisis care and this response work that is in school districts across our Commonwealth. They are sponsoring a For Prepare, and that is workshops, a critical incident stress management CISM training, and a PFA training, which is a train the trainer for current and potential school crisis team members. The goals are to create consistency and best practices for organizations. Currently, we are doing the work helping to supplement in areas where crisis teams don't currently exist, and to bring partners together to discuss unmet needs, current trends, and of course, evidence-based practices. Another initiative here in Kentucky is our crisis continuum, which the last bullet. Of course, if you aren't aware, DMS's most recent efforts to expand Kentucky's mobile crisis continuum was not funded by the General Assembly, so we are currently reevaluating our efforts. On a brighter note, I just wanted to mention that we have been so very fortunate to move forward with the Cabinet's municipality grants, and we've awarded those to 7. And I'm just going to list those out so that you're aware, and they may be in your nearby areas. You might be interested. That's the Perry County Ambulance Authority, the Bull County Fiscal Court, the Lexington Fayette Urban County Government, Warren County Sheriff's Office, Cynthiana Police Department, Maysville Police Department, Christian County Fiscal Court, and I am happy to report that all of them are flourishing, currently flourishing in their efforts, and they've exceeded expectations with the milestones. So we will continue to watch over this as a pilot project, and it will be lessons learned for us about how we can continue to that work in Kentucky. Thank you.
Kentucky Medicaid also has several 1115 waiver initiatives to help expand services. An 1115 waiver is an opportunity for states to ask the Center for Medicare and Medicaid Services for an opportunity to bend the rules and do some things different than normal. Upon approval of those 1115 waivers, then Kentucky Medicaid can change regulations or start initiatives to expand services. So currently, Kentucky was in the first cohort of 4 states to submit a reentry 1115 application to CMS. We're hoping to have approval by the end of July. And some of the objectives are suspension from benefits and not termination for people who are incarcerated, pre-release services, case management, MAT, and 30 days of medication supply on release. So Kentucky was also one of 5 states chosen to be in a reentry learning collaborative, and we're excited about that opportunity. Next, we have the SMI 1915I for SMI and SUD individuals. That public comment period is currently underway, so we encourage anyone who would like to have more information about that or make a comment about that to check on the DMS website for that opportunity. That will include IMD expansion and a recuperative care pilot, which we're very excited about. There's also some early work going on a children's social determinants of health initiative with DCBS. It's the very early stages, so we're not sure if it will end up as an 1115 waiver or a 1915I, but we're certainly looking at partnering with DCBS to help with some children's services.
Sherry, if I may, I just noticed something on the slide, if that's okay. So we have 2 initiatives for SMI. We have an SMI 1115 waiver and a 1915I state plan amendment. The 1115 waiver has been with CMS for since last May, and that we're trying to work on that now. And then the 1915I just had public comment and is with CMS.
Thank you. Also wanted to talk a little bit about our certified community behavioral health clinics. This is a current demonstration that began in 2023, and we added CCBHCs to 4 provider sites who applied and were part of the demonstration. Those current sites are North Key, New Vista, 7 counties, and Pathways. The CCBHCs must provide care regardless of ability to pay or place of residence, providing care for those who are on Medicaid, uninsured, underserved, homeless, or for active duty military or veterans. CCBHCs require quality control through evidence-based practices. There's been a community needs assessment through part of this demonstration, some provider technical assistance, and we plan to expand in the future, but this demonstration will end in 2027. This is just a way for there to be another payment system and opportunity for folks to be able to receive services in communities. In school-based behavioral health services, there's lots of initiatives going on with that right now. It's really exciting because we're expanding work into schools. Kentucky has historically delivered school-based behavioral health services and supports through a variety of models across the state. After the return to in-person learning, there was an outcry from schools that they do not have the expertise or capacity to meet the increased volume and acuity of their students' behavioral health needs. And as a result, there's an increased focus on collaborating across state agencies to provide more comprehensive school-based behavioral health services and supports. We are fortunate that our Lieutenant Governor is a former educator who has prioritized student mental health, and she and her staff hosted a series of student mental health action summits that have led to policy and practice recommendations that are currently being implemented by multiple state agencies. Kentucky has been fortunate to have received 3 SAMHSA C Project Aware grants that have allowed selected districts to build and enhance multi-tiered systems to support student behavioral health. Additionally, the state was recently awarded several full-service community school grants. And Kentucky has intentionally embedded mental health promotion and illness prevention along with treatment services and support within an MTSS framework in Kentucky schools. For example, evidence-based strategies related to social emotional competence, suicide prevention, and substance use prevention are available to Kentucky schools at no cost. And some of those are sources of strength, youth and teen mental health first aid, etc. The CMHCs provide clinical and support staff to schools within their regions, and however, staff may not be available to all schools. And a variety of other community health agencies also are employed to provide clinical services in schools. States and federal funds have been leveraged to support school districts in hiring behavioral health staff to increase access within their schools as well. So lots of initiatives with school-based mental health. And now Tammy and Beth will discuss evidence-based practices.
Thanks, Sherry. So still we're talking about services and supports in response to the crisis. So implementing a continuum of evidence-based and evidence-informed practices is one of the guiding principles of the system of care that we mentioned earlier. In response to the crisis, Kentucky prioritized building capacity in several evidence-based practices as shown on the slide. You can see there's a variety of approaches, including clinical interventions, care coordination, a modular approach, in-home, recovery-focused, early childhood and teen-focused, as well as family group supports. These approaches focus on expanding the reach of existing professionals, including clinicians, care coordinators, peers, and others. The first few approaches focus on training and coaching for clinical staff in specific interventions, and those are multisystemic therapy, high-fidelity wraparound, managing and adapting practice, attachment and biobehavioral catch-up, racial trauma therapy that we talked about. And then several of the practices are focused on supportive services, including parenting supports, recovery supports, and youth supports, as well as mental health awareness. Tammy will now discuss how the Kentucky Partnership for Families and Children offers training and support statewide in some of these practices through its regional peer support centers and other interesting and exciting things happening with the peer support centers.
Thank you, Beth. Just very quickly, just to kind of familiarize folks with the idea of peer support. Peer support is a service that is provided by individuals with lived experience. So they have received special training. It was recognized as an evidence-based practice, gosh, back in, I think, 2007 now by the Department for Health and Human Services. There are different ways to go about it, to provide it. But there are many benefits to peer support. One being it can occur in those areas where other providers or services may not be able to access or otherwise reach. It is very helpful for individuals with significant barriers to service participation, such as transportation, childcare, so on and so forth. So very quickly, for the sake of time, yes, the Kentucky Partnership for Families and Children was very fortunate to provide peer support under System of Care 5. And we, as you can see outlined on the slide here, our primary focus at that time was families who had child welfare involvement. So you kind of had some specific parameters. And now that we have moved into Kentucky 6, our reach has been expanded. So now there are families with children and youth who are at risk for, or have already been, assessed or otherwise diagnosed to have specific needs, and or have juvenile justice involvement. So the point here is what started out with one focus has now been expanded, and we have been able to increase our reach and increase our impact. So we are currently in 6 DCBS service regions. It is a service that, again, if some of the other barriers that might be present when receiving other types of services, we don't necessarily have to worry about those same challenges. And then lastly, something that I'm very excited about is that we have had the opportunity to partner with UKHDI, the University of Kentucky Human Development Institute. And basically the point with this last bullet is that we have been collecting some data. So even, excuse my typo there, it should say evaluation data. to guide CQI efforts and identify strategies to continue peer support. So when the next slide, please. And finally, this is just an overview of our mission and vision. And family-run organizations such as KPFC are both proud and committed to being a part of the system of care collaborative response. So we feel that we have a valuable and much needed place in the system of care. And as things evolve and as the community takes the approach of leveraging the collaborative response, we intend to be there every step of the way. So thank you. And now I believe it's Mary and Dr. Lohr.
Thanks, Tammy. So at DCBS, we really have been committed to really lifting the voice of lived experience as well, and building on what Tammy mentioned about peer support, improving engagement with youth and families, and how we respond to families. And so Kentucky was an early implementer of the Family First Prevention Services Act back in 2019. We're actually coming up on the 5th year of that, which seems unbelievable. But so we have been focused on, reducing the number of children coming into out-of-home care, and then the time that they're spending away from families. And we have seen improvements in that based, by increasing the number of prevention services that we have in our state, really building upon the evidence-based practices that our providers were already delivering and supporting them to implement to fidelity. And we have are currently implementing an alternative response. So that's really a different approach to how we work with families. We're partnering with the Kemp Center and U of L to implement that. So we're fully implemented in 2 service regions. We're currently implementing and in the process of implementing in additional service regions, and plan to be implemented in 2025 in the entire state. But that we worked with lived experts to develop some materials to hand out to families to really promote how we want to be seen differently in this new approach to working with families. And then we're intentionally partnering with peer support in those service regions to deliver services differently to families. We're also implementing community response. I mentioned earlier those screened out reports. So really trying to support families outside of our system. We're partnering with the Doris Duke Foundation to have some additional funding to offer concrete and economic supports. We know offering families those supports to meet those concrete and economic needs, their basic needs, so that they have what they need to be able to meet those daily needs is really important. In addition to having those treatment needs met is really important. So we're doing that as well. And then we can go ahead and go to the next slide. I know we're moving away from time. So really thinking about the infrastructure too. So I will briefly mention we have a new division of prevention and community well-being that was developed as a result of a reorganization. So that is sort of the infrastructure for supporting our all of our prevention efforts. And then something that we've implemented is universal screening and assessment. So back in, I think probably about 8 years ago, we implemented as part of a federal waiver, a standardized screening for children in out-of-home care. So that was 8 years ago. I'm thinking, checking my time frames, but and then as part of our work with system of care, we were able to move that to our in-home cases. So we actually started in some pilot regions, and we moved actually to statewide. And so really the importance of standardized screening and assessment is to address those child behavioral health needs sooner. With the out-of-home care, we were really looking at enhancing placement stability, permanency, and then that continuity of care, to have that communication between behavioral health provider and DCBS, and really, having that ongoing monitoring to with the CANS assessment, which is what we're using, that's re-administered. And so now we have that standardized screening assessment for in-home cases and out-of-home care. I see Lizzie there. She's really our guru for our CANS and screening assessment. This is really giving us a lot of really good data now that we're 8 years in. So, really helps with that feedback loop between providers and child welfare, and making sure that, especially with the expansion to in-home, that they're getting those services sooner and supporting providers with those referrals. And I will pass it to Dr. Lohr for this next slide.
Thank you, Mary. On the high acuity need, these are youth that had special needs. And so you think about all the levels of care that they may benefit from. As I said, we have youth in offices that we're working hard to find them placements. And so we have special contracts that DCBS has authorized for emergency shelter beds that allow for 30-day stays. Currently, there are, I believe, 11, 8 male and 3 to 4 female beds at a couple of at St. Joe's Peace Mission in Western Kentucky and Home of the Innocents in Louisville. We're looking to expand that. These youth have a lot of needs, and so we try to get them talking and get involved in therapy, making sure their medications. It's very important for them to have their voice being represented. So peer support is very important, and it's important to build to a narrative that is trauma-informed, developmentally informed, and also understands what they're working on. At different levels of care, we're looking at residential treatment facilities, and we're also looking at the high acuity youth inpatient unit at River Valley. There are special contracts that allow for residential treatments and inpatient hospitalizations for those youth that need that level of care. But we're also really working to keep kids in the community. So that means increasing rates for providers in the community, foster homes, and as well as QRTP, congregate care facilities. And we're working really hard to develop more effective and intensive foster care programs to keep them in the community with their families. There are a lot of things happening. The Policy Academy is one way that members of the cabinet are looking at different options for that. We can get together and help. Next slide. And Beth, that's probably you to take us home. Or Tina?
I think it's me, Dr. Lohr. So we are certainly doing a lot, and you heard just a smattering today of some of the responses, collaborative responses that we have going on. And so we wanted to stop and think about how we're leveraging this system crisis to create opportunities. And so Albert Einstein once said, in the midst of every crisis lies great opportunity. And so this children's behavioral health crisis is no different. We believe that there are at least 3, sort of large scale lessons learned from this crisis that has allowed and is allowing us to create opportunity that will benefit the system of care and ultimately our families and children. And so the first lesson learned is that we have to have an intentional adherence to the system of care approach. That's crucial to supporting a collaborative and coordinated response that's not merely reactive in nature, but also focuses on identifying prevention and early intervention strategies that will reduce over-reliance on intensive, high-cost responses. And having said this, we're currently experiencing extreme strain within the system, as Dr. Lohr and Mary and others mentioned, resulting in youth boarding in non-traditional settings. And we're balancing the pressure from, elected officials and media and families and providers to create more acute care options more inpatient and residential, with the need to simultaneously expand availability of and access to more community-based promotion, prevention, and early intervention treatment and recovery supports. And so it's a bit of a tightrope walk, if you will. So again, adhering to that systemic care approach, those values that Beth talked about, is critical in a crisis situation. The second lesson learned is that utilizing Kentucky's existing system of care governance structure and resulting cross-partner relationships meant that we could respond rapidly in a collaborative fashion. And I think you've seen that illustrated here today. The absence of an existing structure like that would have delayed our ability to respond effectively and efficiently and in a collaborative manner. And then finally, and perhaps most importantly, we learned that in the midst of a crisis, the design of the response cannot be top down. There must be multiple opportunities for all stakeholders, and most importantly, those with lived and living experience and expertise, to contribute to planning for and implementation of strategies that ensure a variety of response types aimed at meeting state, regional, and local needs. And you heard some examples of that: student mental health action team meetings, the judicial mental health summit, these work groups and committees, and just a variety of ways in which we have been able to gather critical stakeholder input from multiple perspectives. And so those are really the ways in which we have leveraged this crisis to find opportunity. And so I believe we are at time. You'll see a few references at the end of the PowerPoint, as well as all of our contact information. If you heard something that you want to know more about, or something that you would like to get meaningfully involved in, please reach out to us. We need, as we said in our last point there, our last lesson learned, we need multiple perspectives to help us create effective responses to this crisis.
I just want to say thank you to all of you for being here today. We did meet up right at the end of time. I don't see any questions in Q&A or the chat. If someone wants to stick around for a couple of minutes to ask a question, feel free. I'm confident that at least a couple of our presenters could stick around to answer those. Otherwise, everyone is free to go. Don't forget that you'll be receiving your evaluation link and an email from me within about 2 weeks. Thank you guys for being here today, and thank you again to our presenters. And you're getting lots of thank yous and great jobs. And thank you to our interpreters too. You guys worked hard today. We have someone with a hand raised. Let's see. Francis, did you raise your hand on purpose? Sometimes people push the button accidentally. Okay, Francis, you can unmute. You're unmuted if you want to ask.
Yeah, I was asking, but it wasn't coming through. Is it coming through now?
Yes.
Oh, okay. Sorry about that. I was like, okay, let me type it. I work for the Cabinet for Health and Family Services. I'm the post-adoptive preservation services worker and the subsidy worker. And I have gotten an amazing amount of resources here for us working with our high acuity youth. But I do have a question for you. You had mentioned that SOC 5 was still going. I was under the impression that it was no longer working within our communities. So is it a resource that's still available, or is it no longer with us, or did I misunderstand that?
So funding for the System of Care 5 grant ended last fall. Actually, we got a 6-month no-cost extension that ended at the end of March. However, many of the initiatives and activities we put in place are still happening, like expanding screening and assessment to the in-home population, the secondary traumatic stress breakthrough series collaboratives that Tina mentioned, and just most of the collaborative work continues. So there's no funding and there aren't staff attached to that anymore.
Okay.
However, we did build on System of Care 5 when we wrote the Kentucky 6 grant. So we're starting finally to get staff on board for that. So hopefully you'll be hearing more about that in the coming weeks.
Okay. Well, thank you very much. I appreciate you taking the time, and I
Sure.
appreciate this training. It was really informative. So thank you all very much.
Thanks.
Thank you.
Have a great day. Bye.
And we had one question in Q&A. Are there efforts to include mental health education in the school curriculum?
I'm going to defer to Tina on that because I do think that falls under some of the workforce innovation and development.
Yeah, I think there have been, in particular through Project Aware and a few other specific grant initiatives, opportunities for folks to be trained in mental health first aid, which is a literacy type training. Obviously, the requirements of the statutorily required suicide prevention training for staff and students. And then I think you heard reference to some efforts to train folks, school staff in psychological first aid. And so there are attempts to promote mental health literacy among education personnel. It's, I would say, scattered at this point, happening in pockets, but not a sort of comprehensive effort yet. So great question. Thank you.
That was needed. Okay, I'm going to let you guys go. Thank you all, and I'll be seeing you.